Well, good afternoon. Thank you very much for coming today. This is the Joint Replacement Education class, and my name is Ann Smith, and I am the Orthopedic Program Manager at Providence St. Joseph's Medical Center. This class is part of a larger program that Providence Health and Services has put into place for our patients coming to the hospital for elective joint replacements. So thanks again for coming. So we have about an hour together to talk about a lot of different options and different things. Some of the goals that we are going to be looking at for class today is that you're going to be feeling a little bit more prepared for your surgery. That's really how this class came to fruition, was a lot of patients came in and were very anxious about being here because they had a lot of questions. So I really would like to use this time to answer any of the questions that you have about your hospital stay and the surgery. So you're going to feel a little bit more prepared, and you're going to have all the information that you need to have a smooth recovery after your surgery. So some of the agenda items that we're going to be talking about today are pre-registration and pre-admitting, and we'll talk about that in just a minute. How you're going to prepare for surgery in the days and weeks up until the surgery date. What's going to be happening the day that you come in for your surgery. What to expect once you get here during your stay. Some of the equipment that we're going to be using while you're here in the hospital, and what we're going to be needing to get for you when you leave in order to go home. Pain management. This is a big concern for patients. We want to know what we're going to do about the pain that you're going to be expecting to have. And prevention of blood clots. When you have a joint replacement surgery, you're at a higher risk for developing blood clots. So we're going to talk a little bit about the things that we're going to be doing to prevent that from happening. Physical and occupational therapy and what the difference between the two of them are. And then finally, discharge planning and home care, what we need to do to put into place so that you can successfully go home. So some of you have a family member here with you today. In the education books and throughout the class, we're going to be talking about a support person or a caregiver. And this really is going to be the person who is going to be helping you once you get out of the hospital, okay? Can be an immediate family member that lives with you, can be your neighbor. It's just going to be who's that person that you're going to be counting on when you leave the hospital. Ideally, they come to class with you so they have an idea of what's going to be expected. That they come to visit you while you're here, start learning some of the routine with the therapist as you're working and doing your exercises, and then hopefully be around for a week or two after you get out of the hospital to help you with whatever you need. So some of the safety tips we talk about for your hospital stay. When you have a joint replacement, one of the worst things that can happen to you is to get an infection. Okay? So we take hand hygiene and preventing infection here in the hospital very seriously. So one of the things we talk about when I say hand hygiene, and that's just really everybody that comes into contact with you, whether they're coming in to take your blood pressure or bringing you your meal trays, will be cleaning their hands before they enter your room. So we have hand sanitizers that have the alcohol gel in all of the rooms, and we also have sinks in each of the rooms. So anytime anybody comes in, we expect them to be using one of those two before they touch you, okay? I'd highly recommend that you have your family members utilize the hand sanitizer too, because we're going to work very carefully not to prevent any infections from happening while you're here. We don't want them bringing anything in either, okay? Valuables, for some reason patients tend to bring a lot of stuff with them to the hospital. So we ask that you bring only the basic necessities, and so any valuables, cash, credit cards, jewelry, all that kind of stuff would really be best left at home. There are some exceptions, and we'll talk about that a little bit later, but jewelry and large amounts of cash and credit cards should be left at home. It is okay to bring your cell phone with you. It doesn't interfere with any of our equipment, as long as you bring your charger. All right, so we talked about what we don't want you to bring. Here's what we would like you to bring. We want you to have a picture ID, and this can be a copy of your driver's license or your ID card. Some contact information for your family. And this would be, in an emergency, who is it that we need to be calling and what's the best number to reach them at? A medical insurance card. We require that you have either a copy of your insurance card or the numbers written down so that we can verify that when you get here. A list of medications that you're currently taking is very helpful, including the dosages that you take and the schedule that you take them. An advance directive, if you have one already, if you could bring one with you to the hospital so that we can scan that into your electronic record. And we'll talk about advance directives in a minute. If you are currently using something, an assistive device to walk with, so if you're using a cane or a walker, we want you to bring that in the day that you come in. If you are planning on borrowing one from someone prior to coming into the hospital for your use, we don't necessarily need that on the day of your surgery. We will have equipment for you to use while you're here in the hospital, and then when you are discharged, we'll be concerned about that. But if you need something to walk in here with, we want you to bring it with you. Clothes that are easy to get on and off, and this is really for the day of discharge. We want you to have a very comfortable, easy to get on outfit so that when you are getting dressed to go home, you'll have dressings to get over, so you're not worrying about something too constricting or struggling to get onto something. So elastic waist, large fitting t-shirts, dresses, that kind of thing are very helpful to have. A comfortable pair of shoes and socks. This is because our therapists like you to wear your own shoes and socks when you work with them. And the best pair of shoes are a pair of tennis shoes. So they have rubber soles, so nice tread on the bottom, and they lace. So nothing slip-on, because that's not necessarily safe. So a good pair of tennies is good. And then any personal items that you need, like your glasses, your dentures, hearing aids, contact lenses, any of that kind of stuff that you need day to day. And then that phone charger. Okay. Phone's only as good as it can be without the charger, right? Okay. All right, so here's just a brief discussion about advanced healthcare directives or advanced directives. Does anybody have one already? Okay, perfect. So again, on the day that you come in, if you want to bring us a copy of it, we can scan it into your electronic record. An advanced directive is really just a legal document that you prepare in case you are unable to make decisions for yourself. If you don't have one already, we can give you some information when you come into the hospital about filling one out.
Yeah, when you talk about that, because the last time I was here at the hospital, they said that somebody here could actually do one for us.
So we can provide the documentation for you, the form. It does not have to be notarized to be effective, but it does have to be witnessed by 2 people, and the 2 people cannot be employees of the hospital. So if you do want it to be witnessed, they'd have to be friends or somebody else. We're not allowed to witness that document.
So is that something I could pick up now before I leave and then
Sure.
take to a notary? And
Our admitting department should have some, if you want to, yeah. Mm-hmm. Yep. Yes.
I got one at the admitting department, and it says on it you need 2 people to sign it.
Correct.
Or if you don't have that, you need to have it notarized.
Notarized, correct. Yeah. So just the 2 witnesses, though, cannot be an employee from the hospital.
Right, but if you don't have any witnesses.
You can have it notarized. Yep.
Notarized.
Yep. That's correct. Yeah. Okay. Good questions. All right. So preparing for surgery. For those of you whose surgeries are a week or so off, the conversation should have taken place already with your surgeon about what medications we want you to hold off on taking. And everybody kind of knows about aspirin, that aspirin's bad to take before you come to have surgery because it thins your blood. But we also ask that any kind of ibuprofen products you try and hold off on taking for about a week before the surgery, because ibuprofen can also have an ability to disrupt your clotting and your ability to bleed. So we ask you to try and stop, and that's usually about a week beforehand, okay? Anybody currently taking any blood thinning medications like Coumadin, Plavix, anything like that? Okay, great. All right, and then also herbal medications. So the herbal medications, and I'm talking about vitamins and nutritional supplements that became very popular a few years ago, these are not regulated by the FDA, and because they're not regulated by the FDA, we don't always know what the side effects are of some of these medications. So instead of trying to figure out which ones are safe and which ones aren't, we just want you to stop all of them for about a week before the procedure as well, okay? There's generally not a problem with resuming any of these medications after your surgery when you go home. It's just that week before, we just don't want it to affect your bleeding. All right. So before your procedure, we're actually going to have you take a special shower, and this special shower is actually 2 showers. And we're going to have you use a special medicinal grade soap called CHG or chlorhexidine, and you're going to make an appointment to come and visit our nurses, pre-screening appointment. So we'll talk about that after class a little bit, but there's an appointment that you'll come and meet with the nurses, and they'll actually be dispensing the soap to you. So you get a small bottle of soap. The night before your surgery, we're going to ask you to shower using half the bottle of soap. And then in the morning, when you come in for the surgery, right before you come to the hospital, we want you to take another shower and use the other half of that bottle of soap, okay? And what that does is it's, again, a medicinal grade soap that it really is just kind of washing the surface bacteria off of your skin. Remember, we were talking about infections are probably one of the worst things that can happen to you after your joint replacement. So this is part of our process and our policy now that we want you to do all of these things to limit the possibility of developing an infection after your surgery. So the soap is a medicinal grade again, so we don't want you to get it in your eyes. So I have patients who tell me they use their own shampoo to wash their hair, and then they use the soap from the neck down. Okay, so don't get it in your eyes and don't put it in your hair. Okay. Now for ladies, we ask that you don't shave for about a week before you come in. And that's because any type of minuscule nick that you might accidentally get as you're shaving can be an opening in your skin and lead to an infection. So again, we won't think badly of you if you come in with hairy legs. We just don't want to have any risk for infection. So, all right. So I generally say that we don't have homework in this class. However, there is one thing that I do want you to go home and do tonight, and that is look at your house when you're walking through the front door tonight when you go home as if you were using a walker, okay? Because more than likely that's how you're going to be returning home. Now when you use a walker, you have to kind of think about things because walkers are a little wider than your hips are. So if you have furniture that's too close together, if you have a lot of throw rugs, if you have extension cords or something that might be trip hazards, this is what I want you to be looking for. And we want to remove all those things before you come in for your surgery. So you need a path from the front door to the bedroom, to the bathroom, to the kitchen, wherever you might need to maneuver around the house, and make sure that it's wide enough that you're going to be able to get through. It's a lot easier for you to manage all of this stuff now than the day that you go home and then have to worry about moving the furniture. So we want you just to plan ahead. If you have animals, who's going to be taking care of the animals? Just as long as you got a plan, okay? Medications, and these are the medications that you're currently taking. Your diabetes medicine, your thyroid medication. We want you to make sure that you have an ample supply of those medicines when you come into the hospital. The last thing we want you to do is the day that you go home after your knee replacement or your hip replacement is realize you only have 2 days left of blood pressure medicine and you have to run over to CVS. So make sure that you have an ample supply to last you for a little while. All right, so the registration appointment, this actually happens over the phone. The hospital is going to call you about a week before you come into the hospital, and they'll be asking you information about your address, your phone number, and your insurance information. So they're verifying all of this information over the phone before you come in. Pre-admitting appointment, or the pre-screening appointment, is actually with the nurses. Now this appointment is going to require, you don't have to have an appointment, but I would highly recommend it. And when you make the appointment with the pre-screening nurses, they're going to be going over your medical history. They're going to be dispensing that soap to you. They're also going to be doing a test called an MRSA swab, which is a Q-tip where we take a little swab on the inside of your nose checking for a bacteria. That's going to happen at this appointment. And they're going to go over and make sure that everything that we need to have in place before you have your surgery, all of your lab work, your EKG, your chest x-ray, everything is complete. Okay, and this should take place about a week before your surgery as well. Okay. The surgeon's office will tell you what time you need to arrive at the hospital the day of your surgery based on what time your surgery is scheduled for. Once you have registered over the phone with the hospital staff, you will check in with the admitting department on the day that you come in at that designated time. So once you've checked in with admitting, they will be sending you to our short stay area, which is on the south tower of the second floor, and somebody will escort you over there. It's not a very large area, so if you have a whole truckload of family members that are coming with you, we may not be able to accommodate everybody, but a few family members can join you over there. And this is really where we really start the process of getting you ready for surgery. We get you changed into a gown, pack up all your belongings, and get things started. So this is the area where you're actually going to get to meet the anesthesiologist. So I would highly recommend that you have a very good conversation with this person, okay? Everybody who's had surgery has a good story about anesthesia. what went well, what didn't go well, and you're nodding your heads. So this is the person you want to share with any other experiences that you've had that may not have gone really well. We have a lot of advances in anesthesia now where things are being offered to you that weren't available 10 years ago, okay? But the anesthesiologist can do a lot, but they can't do something about something they don't know. So share with them the stories about, you know, your nausea every time you have general anesthesia, the time you woke up in the middle of a colonoscopy, you know, just any, and you laugh, but there are a lot of people that have these kind of stories out there. So this is the person you really want to have a good quality and conversation with and let them know how you've done in the past. This is also where you're going to get to see your surgeon, and they will do something called site marking. And site marking is just where they take a special marking pen and they're going to put their initials on the body part that we are going to be operating on, so that you and he both know that you're here for the right procedure, okay? And the marker does eventually wear off. All right, so once we've got everything ready to go to surgery, we're gonna be taking you over to the operating room. This is where your procedure is gonna be performed. One of the things that happens in the operating room that many patients don't know about is something called a timeout. And this doesn't mean that you've been naughty and we're sticking you in the corner. It's actually just a policy that we do here at the hospital that everybody that's in the operating room that participates in your care, everybody stops talking and one person says, okay, this is Mrs. Smith and she is here for a right total hip replacement with Dr. Stephen Yacoubian today. So we all know, and you actually may hear this because you won't have had any anesthesia yet. So it's not that we don't know what we're doing. It's again, just so that everybody knows exactly what procedure you're here and you're having it done by the right person. So once you're done in the operating room, you're going to be going over to recovery. And this is really just where you're going to be wakened from anesthesia and the nurses will be monitoring you very closely until you're awake. While you're in surgery, there's a designated waiting room for your family. And this is where they will ask them to wait. If they would like to speak with the surgeon after the surgery, they need to be waiting in the waiting room after you're done. Uncomplicated joint replacement surgeries take between 1 and 2 hours for the surgery itself, and then you can expect to be in recovery between 1 and 2 hours following the surgery. Okay, so potentially 3 or 4 hours that you're away from your family. And again, they'll be kept abreast of everything that's going on. There's a little tracker in the waiting room so they can see when you leave surgery, when you go to recovery, and then the surgeon will be out to talk to your family members when you're done. And if there's any sort of delay, your family will be notified. So barring any complications during surgery, you'll be going to the orthopedic unit, and that is over on the northeast tower on the 5th floor here at St. Joseph's. And this is where we're going to be bringing you after your stay in recovery for your stay while you're here in the hospital. So there's several people that'll be caring for you while you're here in the hospital. You will have a licensed nurse with you at all times. The nurses generally work 12-hour shifts, so you'll have a day nurse and a night nurse. The registered nurses will be basically checking in on you, monitoring your vital signs, overseeing your care. And then we also have nursing assistants that will be helping the nurses out. They'll be responsible for helping you with your meals, toileting, and showering. And then physical and occupational therapy. We have therapists are twice a day here at the hospital, and occupational therapy is once a day, and we'll talk a little bit about that in a little bit. And then you'll be getting a visit from either the surgeon or surgeon's assistants once a day. Somebody from their office will be coming and rounding on you at least once a day. Yes?
On uncomplicated surgery, what is the usual stay in the hospital?
About 2 days after surgery. Yeah, and that would be if your surgery is on Monday, Tuesday is day 1, Wednesday is day 2. So 3 days including the surgery day, but most of our patients are leaving on the 2nd day afterwards. So in each of the rooms we have something called a communication board, and this is basically just a white dry erase board that we have in your room that we are going to be using to relay information to the caregivers and to you. So when therapy works with you, they will be putting your progress on this whiteboard. Okay, so every day that you get therapy, they'll say, okay, today Susan did 100 feet, but we know she's got a flight of stairs to go up, so they'll be all on the board there. And so you'll know exactly when your family comes in, they'll know exactly what you've accomplished and what we still need to be able to do. Okay, so going to the orthopedic unit, okay? In the rooms on the orthopedic unit, they're all private rooms. There is Wi-Fi in each of the rooms, and there's a TV in there, and there also is the capacity to have family members spend the night. So in the back there's like a futon daybed kind of thing, so if your family would like to spend the night with us, they're more than welcome to. Can't guarantee it's the best night's sleep they've ever had, but they're welcome to stay the night with us if they'd like. We will be feeding you after surgery. We do tend to go a little slow with the diet, just because nausea is a fairly common thing after surgery. So we'll start you from ice chips to liquids and then to solid food. If you do have any special requests for your diet, vegetarian, kosher, heart healthy, any of that kind of stuff, just let us know and we'll take care of that for you. Our diet techs come in and they'll take your menu choices every day, so you will get to choose the selections that you get served here in the hospital. How many of you are having knee replacements? Okay. So this is something called a CPM, or a continuous passive motion machine, and this is going to be utilized as part of your therapy while you're here in the hospital. We'll be starting this the night of surgery, and what it does is it will strap your leg into this, and it just very gently straightens and bends your knee to get range of motion to your new knee replacement. Not all of our surgeons use this, but if your surgeon does, you will be receiving this the night of surgery. And for some of you, you will be going home with one of these as well for a couple weeks to continue as part of your therapy. One little side note there, it talks about pillows under the knees, and that's a big no-no after you have a knee replacement. We don't want to have, which generally does feel good when you stick a pillow underneath there, but when you have a brand new knee put in, it can also lead to a contracture or stiffness in your knee so that you don't bend it straight anymore. So we don't want you to have any pillow underneath your knee where your knee is resting in a flexed position. You can put a pillow underneath there, but it should be underneath your calf so that when you're resting, your leg is fully extended. Okay? And this is when you go home as well. So there will be a lot of things attached to you after surgery. You will have an intravenous line. This is going to be put in before surgery, and this provides hydration for you. You also will be getting antibiotics for the 24 hours that will also go through the IV after the surgery. You will have a catheter. The good news is the catheters don't stay in for very long. It gets put in during surgery, and then it'll get removed the following morning. Okay? The longer catheters stay in, the more likely you are to get a bladder infection, so we don't like them to stay in for too long. If you do have a drain put in, it's just a very small tube that goes into your incision that drains any extra fluid from around the surgical site, and then also generally gets removed the next day. Pain management, I promised we'd talk a little bit about that. So one of the big concerns for people after they have this surgery is how much pain are you expecting to have, and then what are we going to do about it? Okay. So this little happy face ruler here is posted in each of the rooms, and this really is something for us to use for patients who can't communicate with us very well. Show us how you're feeling, okay? But for those of you who can communicate with us, we will be asking you to rate your pain on a scale of 0 to 10. 0 meaning no pain at all, and 10 being the worst pain you've ever experienced. So when the staff comes in to ask you about your pain, give it a number, okay? And everybody will ask. The doctors ask you, the therapists ask you, the nurses ask you. So just, when they come in, just don't say, oh, it's not too bad today. That doesn't mean much for us, so give it a number, okay? It's not very realistic to expect to have 0 pain while you're here. What is expected, though, is that our goal is to give you a number that you're calling your pain so that you can still participate with therapy, but we've done something to you, okay? And for everybody, that's something different. Pain is very subjective, so it is what you tell us it is. But we got to get it to a number where you can do all the things we want you to do. And how are we going to do that? So we have a couple different things that we use for pain management. So the night of surgery, when you come back, if you're having any discomfort, the nurses will be giving you medicine, most likely through the intravenous, okay? And that's because you haven't eaten very much and you're not terribly awake. So if you need something, we'll be giving it to you IV. Starting the next morning, however, we are going to try and transition you on to oral pain medications in a pill form. And the reason why we do that so quickly is that IV pain medications work very well, but they don't last very long. So when we give it to you, it takes about 15 minutes. You're starting to feel a little bit better, but it only lasts for about an hour or so, and then you're having discomfort again. So starting the next day after surgery, we have a lot of things we want to accomplish with you. And so for that reason, we want something that's going to last a little bit longer than an hour or so. We want good chunks of time that you're comfortable so we can participate with therapy and occupational therapy and everything else we need you to do. and pills do a much better job doing that, okay? So the oral pain medication is as soon as you're able to tolerate breakfast, the following morning we're going to try and find something in a pill form that works for you. Ice, we use a lot of ice here. Icing helps with swelling, and the less swelling that you have, the less pain you're going to have. So we will be putting on ice or gel, refreezable gel packs right after the surgery, and this is something that I will encourage you to do when you go home as well, and you just need to be very consistent with it. Because again, the less pain, the less swelling you have, the less pain you're going to have. Epidural, spinals, and nerve blocks. These are some of the most common forms of anesthesia that the anesthesiologist is going to talk to you about. Now, this is very patient dependent, meaning depending on what your history is, they will be discussing what options they can offer for you, okay? Sometimes if we have patients who come in and they've had a lot of back surgeries and have metal plates and screws in your back, sometimes having a spinal may be a little problematic, okay? But for that reason, the anesthesiologist will talk to you based on your history, what we can offer for you, okay? Another new thing that we started doing last year is being more proactive about pain medicine. The therapists, when they start working with you the following day after surgery, we have assigned appointment times with them. So they will be coming in and we'll know your appointment today is at 9 o'clock and 2 o'clock for therapy. So about an hour before those appointment times, the nurses will be coming in and giving you pain medicine. Okay, it's not that you just have asked for something. The nurses know to just be proactive and to medicate you about an hour before therapy. Okay, so I would highly recommend that when they show up magically with a tray of Percocet, you take them because we know what's coming and we want to stay ahead of your pain. And it's really just, it's as simple as that. It's all about, at this point, managing your pain well so that you can do all the things we want you to do. And it's something, a philosophy that you're going to need to do at home as well, because you're going to have home therapy. They are going to be coming out to your house to work with you, so you want to be ready for them when they show up as well. So we'll start training you how to do that while you're here in the hospital. Maintaining healthy lungs. One of the things after surgery that we worry about is pneumonia. So this thing, anybody used one of these before instead of spirometer? Okay. So this is something that we're going to ask you to do the night of surgery and every hour while you're awake, 10 times. It just helps to fully inflate your lungs and combat the effects of anesthesia. Same thing with just coughing and deep breathing. Does the same thing, inflates your lungs and kind of clears all those gases from anesthesia out of your lungs. So this is the screen that nobody really likes to talk about. But it is probably the #1 complaint of most patients after surgery. I say it's like the perfect trifecta. You've had a surgery where you're not moving around very well, you're not eating and drinking normally, and you're taking medicine that the #1 side effect is constipation. So those three things combined are going to cause this to be a problem. So one of the things that we do here in the hospital for you is you will automatically be put on a stool softener. You will be getting that twice a day while you're here in the hospital. We need you to do your part by making sure you're drinking plenty of fluids and making good choices on your diet. So whole grains, fruits, vegetables, natural things to help combat that problem. And then we also have some additional medications that we can offer to you here in the hospital in case the need arises that none of the rest of this stuff has worked. Okay? I would highly recommend that you have one of these medications listed at the bottom there, one of these at home. Because just because you leave the hospital doesn't mean that this problem goes away, because you're still taking pain medication, and all of these medications can be bought over the counter. They do not require a prescription. So I would recommend that you have something just in case. All right, we talked about being at a higher risk for developing blood clots in the hospital after the joint replacement surgery, so there's a few things that we're going to do to prevent that from happening. One of them is a simple act of something called ankle pumps. So it's when you're laying in bed, you have your feet and you're just moving like you're stepping up and down on a gas pedal, okay? Moving your feet up and down. And what that does is helps get the blood that's pooling in the back of your calf, and that's where blood clots generally form, gets that pumping back up to your heart, okay? And then also something called SCDs, or the squeezers they're called. These are the wraps that go on your calves. So while you're in bed, you'll have these, and they just intermittently inflate and deflate and help pump that blood back up to your heart. So those will be on while you're in the hospital, while you're in bed. And then the third and most important thing is getting you up out of bed as soon as we can. And that really is the most vital thing that we can be doing for you, because we know historically the longer we let you lay around in bed, the more bad things happen to you. So getting up and moving quickly is a key to success. So for all of you, this will be the night of surgery. So we'll be coming in as soon as you're awake after surgery. The therapist will be coming in to work with you. And it may be just sitting on the side of the bed. It may be getting up, maybe taking a few steps. You could be walking down the hall. You're really, because of anesthesia, you are capable of doing amazing things the night of surgery because you're not really having a lot of discomfort. So we want to get you up and moving if we can. So have your family bring the video cameras. All right. So one of the things, in addition to all of those things that we talked about, preventing blood clots, that's not quite enough. We have to also put you on some form of medication. We use a lot of Xarelto, which is a pill form of a blood thinner here in the hospital. You may not necessarily go home with that medication because generally speaking, you have to be on the medication for about 3 or 4 weeks after you go home on the blood thinning medication, okay, to prevent the risk of blood clots because it's that significant. So we may have you on one medication here in the hospital, and when you go home, we may transition you to something else. Dr. Yakubian is using a lot of aspirin now, and it's not a baby aspirin, it's a 325 full strength aspirin. So that may be the medication that we tell you you will be going home with for another 3 or 4 weeks.
Is that type of aspirin like a Tylenol or a regular aspirin?
It's a regular aspirin. So if you have a problem with taking aspirin, then we'll have to come up with something else for you. And we have a lot of patients who come in who cannot take aspirin. So I'm just saying it may not be the same medication that you're on here in the hospital. We may switch you over to something else when you leave. And just depending on what your history is, we'll talk about finding the right medication for you to be going home with. Did you have a question?
I don't know if I do. I'm wondering why you can't stay on Xarelto.
Some people do. Xarelto is very expensive, and it's hard to find sometimes. And I just had a patient today who their insurance wouldn't authorize it, so they weren't going to cover it because it's expensive. So for that reason, we found it was a lot easier sometimes to send our patients home on aspirin because it's cheap and you can find it everywhere.
They don't have a generic Xarelto?
No, not yet. And until they do, we'll still be dealing with the price. So, all right. So a quick little brief reminder about what blood clots look like and the symptoms that we worry about. So swelling usually in one leg, redness, tenderness. Sometimes patients say it feels like a Charlie horse, cramping kind of a feeling in their calf. You can get a little short of breath. You can start to feel like you have palpitations. So all of these type of symptoms can be the warning sign of a blood clot, okay? And this actually will be on your discharge instructions too when you leave the hospital, so we'll go over it again. All right, so PT and OT, a couple of things that we're going to be talking about. PT, everybody knows what they do. They're the therapists that come in and work with you, do exercises with you, get you up and walk with you. Occupational therapy, on the other hand, are somebody that not too many patients know what they do. And so they're the folks that come in and kind of retrain you for doing things that you want to be doing when you get home. Getting dressed, showering, how you're getting in and out of the car. They're the logistics people, I call them. So they're actually the ones who we fill that form out for, a lot of it, to find out what kind of equipment and what your home physical situation is so that we can start planning and strategizing how to successfully get you home, okay? So a lot of patients will ask me, when do we know when we are ready to leave the hospital? So physical therapy and occupational therapy are really instrumental in making the decision about when you're ready to go, because at this point your surgery's done. You just need to physically learn how to do things so that you can maneuver at home, right? So physical therapy has some goals for you. They want you to be able to get in and out of bed. It says the car there, but not so much the car, more like getting in and out of bed with very little assistance. We want you to be walking about 100 feet, and usually that's with a walker. We do have a few patients who are able to walk out of here with crutches, but the majority of patients, it's a walker, okay? That you're able to do the exercises we teach you here in the hospital, and that if you have stairs to go home, even if it's just a couple of steps to get up to the front door, we've done stair training with you so that you will be able to physically accomplish that, and that we've identified what kind of equipment you're going to need. If you have no equipment at home, no walkers, no canes, no crutches, that we're going to, at least at the very minimal, get you a walker before you leave the hospital, okay? Now, occupational therapy also has some goals for you. So they want you to have a good sense of how are you going to get dressed, because they're going to start teaching you this in the hospital after your surgery. Bathing, toileting, that you're able to safely get in and out of the bathroom when you get home, and that we also identify any equipment that they may feel that is beneficial for you at home. Now, this is kind of my little discussion of equipment. So for the most part, it doesn't matter whether it's Medicare or private insurance. After joint replacement surgery, we will generally get a walker covered. So if you don't have a walker, we will get that taken care of for you. If the therapists, between the physical and occupational therapists, have recommendations of additional equipment that they feel that you would benefit from, like say you don't have anything to sit down in your shower, or you don't have an elevated toilet seat and you're having a hip replacement. So these types of things generally are not covered by your insurance. You may have the one weird insurance that's going to pay for it. That's not the norm though, okay? So I like to preface it by telling patients, kind of expect that if there's some other type of equipment, there probably will be some out-of-pocket cost for you. Now, we have case managers in the hospital that will run through your insurance, getting authorization for things. So we can always do that for you and find out for sure. But just, I like to warn people, you know, back in the good old days, Medicare covered everything that you could possibly need. Those days are long gone. They don't cover much anymore. So we will let you know if there's any other recommendations that we have, you know, if there's going to be an out-of-pocket cost for you.
And if there's something else that you need, is that provided here, whether or not we pay for it or insurance pays for it?
No, that's a great question.
Or should we go out like and buy it?
So I don't really want you to go out and buy a whole slew of stuff. I'd like for you to have your sessions with the therapist and the occupational therapist and find out what really absolutely you need, especially if you're going to be paying for it. Yeah, so for that reason, again, wait until the occupational therapist is going to see you the first day after surgery, and they're going to have a big discussion. They're going to look at this form, see what you've got already at home, and start to strategize and say, gosh, you know what? You're going to really probably need this, and we highly recommend this. And then at that point, then you can go and buy stuff. I just don't want, I've had patients who've come in and bought like one of everything, and they came into the hospital and they're like, oh, I have that. I'm like, how much money did you spend? You didn't really need to buy all that stuff. So we want you only to be buying absolutely what you're going to need at home. So the walker we will get for you here. That is absolutely something that is generally covered without any complications from the insurance companies. It's just the other stuff. And for the other stuff, it's not as important to physically see you for some of those other types of equipment. And again, we can arrange to get stuff for you here in the hospital. You don't have to be on your own to do that. We can absolutely. Again, it may be not the cheapest route to go. Okay. All right. So remember we talked about some of these safety hazards at home that I want you to take a look at and find places for. So throw rugs are very nice, especially when it's cold outside, but they are very much a trip hazard when you're using a walker. And I'm not sure what the deal with the cat is. I hope you don't have a cat that looks like that at home. But you know, extension cords, furniture that's too close together, those kind of things. Okay. All right. So physical therapy, we'll be seeing you the day of surgery. Okay. And this is something that we're going to be expecting. If for some reason you're coming up very late in the afternoon, our therapists work till about 7 o'clock at night. So if you're up on the floors by that time, they will be seeing you. If you are up after that, the nurses will be sitting you on the side of the bed, because we started doing that. That we want you to be mobilizing and to be moving around as much as possible the night of surgery. You're going to have 2 therapy sessions each day in the hospital, one after breakfast, one after lunch. Occupational therapy will see you once a day, starting the following day. And this will progress from sitting you on the side of the bed to taking some steps to walking down the hallway to doing stairs if that's something you need to accomplish. The nurses will help you get up out of bed for meals once it's appropriate with the therapist. And then just a reminder for safety, a lot of patients overestimate their abilities after surgery. So we don't want you to ever try and get up out of bed by yourself. Okay, we want to keep you safe while you're here in the hospital, so always call for some assistance when you want to get up. So here's just a couple of slides of some equipment. So a walker and crutches, it's pretty self-explanatory. And then here's some of the other stuff that we may be having the conversation with the therapists about, okay? So if you, in your shower, if you have a place to sit down, if you're having a hip replacement, this hip kit is some of these gadgets that help you put your shoes and socks on, pick up stuff off the floor when you can't bend over to do that right away. So these are all some of the things that we'll be discussing with therapy. So when you're in the hospital, we will always have equipment for you to use while you're here. Before you go home, we'll identify what things you're going to need and have a plan to get you what you need. Sometimes renting equipment sometimes is an option if you don't think that you're going to need it for a long period of time. Our discharge planners will be working with your insurance company to verify whether something's going to be covered or not, and if it's not, what our next plan of action is to be to get to that, some of that stuff for you. In order to be able to go home, some of the things we need to think about is making sure that you have someone who's going to be available to help you out at home. And it doesn't always have to be someone who is living with you. I have support people in various shapes and sizes. Can be a neighbor who's checking in on you a couple times a day. Somebody who's just going to spend the first night with you when you go home. So it's just, like I said, it comes in all different shapes and sizes. So make sure that person is available, that you'll be able to overcome any obstacles that we can foresee, like stairs. And all of you will be going home with home health, both a nurse and physical therapy set up for you prior to you leaving the hospital, because this is something that is going to be continuing when you go home. You'll have a nurse visit and you'll have physical therapy. And for the most part, home therapy continues for about 2 weeks after you leave the hospital, okay? And at that point, after a couple of weeks, you're moving around a little bit better. And at that point, they're going to try and transition you to outpatient physical therapy where you go to a therapy center. Okay?
So does that mean you can drive?
No. Good question. No. So I would say that for most of you, just the general rule, I'd say 4 weeks, no driving. However, that is your surgeon's decision. So if you're having a right leg procedure, it may be a little bit longer than if you were having a left leg procedure, unless you have a clutch. Then heaven help you. All right, but the doctor will be releasing you to drive when he feels that you're ready. Yeah.
For the in-home nurse and therapist that come to your house, how often do they come a week?
So that's a good question. So the nurses come out maybe once or twice a week, and their job is to kind of monitor your dressings, make sure that you're taking your medication appropriately, the new medication we discharge you, and make sure that you understand any urgent thing that would require a phone call to the surgeon. The therapists are 2 to 3 times a week. Okay, for about 2 weeks, yeah. And it can vary a little bit. If you're really struggling and having a tough time, sometimes the therapists, they can continue for like another week. But for most patients, it's about 2 weeks. So most of our patients are going home that second post-operative day after surgery. So remember, your day of surgery is day 0. Next day is day 1. Following day is day 2. Okay. Our discharge planner and our case manager will be contacting you the next day after surgery just to kind of discuss home health and equipment and those kind of things. On the day that you go home, make sure that you have a comfortable outfit to change into that we talked about. That you have transportation to get home. On certain circumstances, we can help you out with that if you're having trouble finding somebody to take you home from the hospital. It says discharge time is between 11 and 3, and this is really kind of variable. So the day that you go home, we will always know that you're going home the day before. Okay, so we'll look at your progress and say, you know what, tomorrow's really looking like a good day. We're going to be able to get you out of here tomorrow. The day that you go home, you will have therapy session after breakfast. If the therapists at that session feel that you've accomplished everything you needed to do, including stairs and what have you, and they discharge you, we will let you go home after that. If for some reason the therapists feel that you would benefit from the second session in the afternoon, we have you stay after lunch, do another session with PT, and then we release you after that. Okay? So on that day of discharge, it's really when the physical therapist feels that you're ready to go. Okay? Discharge medications, we do have a service here at the hospital that we can get your prescriptions filled while you're here before you leave. If that's something that you would like us to do, I'll mention that to you again when I come to see you in the hospital so that we can arrange for that. You will have that final session of physical therapy releasing you, though, the day that you go home. So when you go home, a couple things to keep doing. Hand hygiene, making sure that you have clean hands. Our goal is not to have you have a lot of dressing changes to be doing when you go home. The nurses that come out to the house will be helping you with that. But if you do anything around your wound, you got to absolutely have clean hands, okay? Calf pumping, those exercises where you're laying in bed, moving your feet up and down and taking nice deep breaths and using your incentive spirometer is something we want you to continue doing at home as well. Just because you get released from the hospital doesn't mean the risk of blood clots and pneumonia go away completely. They're much less, but we still worry, so we want you to continue some of these things. Showering and dressing, I'm not going to talk a lot about because there's very much some variability with that, depending on what your surgeon puts as far as a dressing on your wound and whether or not you're going to be able to shower. For most of you, you will be able to shower. It's just depending on what you need to do to be able to do that. So we'll talk about that when you're here in the hospital. On the days that physical therapy does not come out to the house, we still want you to be doing stuff, okay? So it doesn't mean that it's your day off and you get to sit in the recliner with the remote control and the bottle of Percocet. We want you up and doing stuff. Every couple of hours you should be getting up and walking, doing your exercises. If we sent you home with a CPM machine, we want you to be using that. So you should be doing something every day, okay? All right, so swelling sometimes happens after surgery, and this is where that ice comes in handy. Remember we talked about using the ice to minimize the amount of swelling. So if you do experience a little bit of swelling and a certain amount is normal, that elevating and icing is going to be important, okay? So that will take care of, I would say, 80% of the swelling that you have at home by elevating and icing should keep that to a minimum. All right, when you go home, hang on to that education book. It's packed full of all sorts of good information that you can refer to. Got copies of the exercises in there too to kind of jog your memory when you get home. Again, you will have home health set up for you, both a nurse and physical therapy prior to leaving the hospital. If you have never done outpatient physical therapy before, where you've gone to a center, the back cover of those education books has a bunch of Providence outpatient physical therapy centers that you can take a look at and see if it's convenient for you if you don't know where else to go. And then also you will have a follow-up appointment with the surgeon in 2 weeks after you get out of the hospital. So generally that is set up for you before you come in with a doctor's office. But that's a 2-week follow-up visit, and that is when your staples will be coming out from your wound, okay? And then also we are recommending that you follow up with your primary care physician as well. And the reason for that being is that when you follow up with the surgeon, all they're looking at is your wound and how it relates to your surgery. They're not looking at everything. So if your blood pressure fluctuated while you were here in the hospital, or if your lab work fluctuated in the hospital, and we know that happens all the time, we want you to follow up with the person who knows you better than anybody else. And that would be your primary care physician. So we're talking about, a week or so after you get out of the hospital to follow up with them. So the couple of things that are concerning after you go home, this would be an emergency phone call to the surgeon. So if you start running a fever, anything over 101, if you have excessive drainage from your wound, if you have increased pain that's not relieved by your pain medication, redness, swelling, hardness around your dressing, those would all be a phone call to the surgeon right away. We do not want you to wait for your follow-up visit. We want you to call, okay? And then if you have any kind of experience any kind of emergencies like chest pain, shortness of breath, those would be a 911 call, okay? All right, a lot of discussion. Any questions? No? Yeah.
For surgery, do they normally intubate you?
It depends. If you have general anesthesia, yes. If you don't require general anesthesia, and they look at doing different forms of anesthesia that don't require general anesthesia, not necessarily.
A nerve block is the other type that you don't really? Is that-
Well, a nerve block is, the spinal is where they inject into your back, okay? A nerve block is something that we're doing a lot of for, particularly Dr. Yakubian, for joint replacements. And it's an injection into the nerve that runs down the leg that we're operating on. So they do it in the groin if it's your hip. They do it kind of further down the leg there for knee replacements. But it's like when you have stitches and they give you like a local medication to numb up around the area where they do the sutures. This nerve block is similar to that, where it just numbs up that area. It doesn't systemic, meaning it doesn't go into your bloodstream and affect your ability and make you goofy or anything. It's just numbing that area. So nerve blocks is something that we are doing a tremendous amount of right now, and they're working very well. And the duration of those are about 12, 13 hours. So nerve blocks are not done alone. you get some other form of anesthesia. So you may get a spinal to kind of make you all happy, or a general anesthesia, and then they do the numbing of that particular limb that we're operating on. Okay, great question. Yeah, that's a relatively new phenomenon. I've been doing that for a couple years now. Any other questions? Okay, I will see you on the day of your surgery.